Hello and welcome. I'm going to talk today about graded motor imagery, and this is a chat mostly for my colleagues in physiotherapy or physical therapy working in pelvic health, because it's really hard to find other people to talk to. Often it feels like we're working in a void, and certainly in real true specialities it's hard to reach out to people and find those people you want to talk to. So I'm talking to you all if you're interested in working in pelvic pain and bladder pain syndrome specifically. And if you are, get in touch. I'd love to hear from you. The more people that we can talk and learn from each other, the better our patients are going to get, and the more that we understand. So this is me laying my cards on the table and saying this is what I'm doing, what I'm having success with, and it's not perfect, and it's probably not what you're doing, and that's great. So let's all share. And it's how I've interpreted the data, and I'm probably wrong in parts of it, but let me know. That'd be great. Let's all share. And if you're a patient listening to this, I hope you enjoy it. It gives you an insight into how we think as physios, but obviously you need to have your own healthcare provider look after you, so this is not a substitute for any healthcare, not advice. Don't take it as advice. This is just one thing that I'm doing with some people. Go see someone. Okay, so I want to talk about graded motor imagery. As I said, I'm assuming that we're all up to date on pain, and we know neurotags and limbic system involvement in pain, that we're trying to get that way. And I talk about with patients that we need to do some brain physio to try and take away the limbic control of pain, so that emotional drivers aren't driving pain, pain isn't driving emotional drivers, which is then debilitating. To do that, I talk about brain physio, how we need to get into more of away from our cortisol driven state, so sympathetic activity, balance it more with our parasympathetic activity, and we do that by getting into much more of a parasympathetic state, and I use mindfulness for that. And actually I'm using the Headspace app, the Calm app, there's some books that people like if they hate the voices of the people on the apps, which I think are fine, but some people hate them, so they use books. But just practicing mindfulness to be able to get into a parasympathetic state from which your brain is much more malleable, much more open to changing and making more cognitive leaps. And so a lot of people kind of do mindfulness and they're like, yeah, I'll really get into mindfulness, woo, I'm feeling much more relaxed, I'm really enjoying it. And they do it for 2 weeks and they're like, yeah, it's really hard, I can't always stay focused. And they expect their pain to change, but that's not what it's about. It's about practicing and getting the skill of getting into that balanced state from which we can change. So a lot of the time I'll send people away for 6 weeks and say, I need you to practice and practice and practice. It is a skill like any other. Getting into a parasympathetic state, or getting into a much more of a calm zone from which you're able to switch off the rest of the bears, all of the other threats around you, environmentally, socially, within family, lots of other stuff, to some degree, so that you can just focus on the one thing I want you to focus on. And from what I've read, being in more of a parasympathetic state, much calmer, less cortisol and adrenaline, we're less likely to be triggering a threat when we're doing this, which is why Anderson and Wise's paradoxical relaxation works so well. So parasympathetic state, mindfulness, 6 weeks-ish. Some people are longer, some people are shorter. Once they're in a parasympathetic state, or they're good at getting themselves into it quickly and regularly, and it could be 10 minutes, it could be an hour, it takes whatever they're doing, then we work on building the best image of their bladder. So like building your best self. And if some of you have been on my courses, you'll have seen videos of patients working through proprioceptive exercises, where we start with the same as we would CRPS, which side of the hand are you looking at, up, down, left, right. We start with images of outside of the pelvis, Strictly Come Dancing dancers, because there are lots of Strictly fans in my patients, or other people, so that people are in complex positions. They start easy, lots of imagery, you can see the head, the bottom of them, so that you can really make a decision on what side is facing you, and then working down to just actually working on the pelvis, so that we get a bit more of a brain engagement about where our pelvis is to begin with. Start with the pelvis, then we move on to the internal organs. Internal organs is difficult because you've never seen them, your proprioception is poor. So what I do is I get loads and loads of graphic images of inside the pelvis, and by graphic I mean like nice, not graphic. Cartoons, so they're non-scary, and I'm really looking for the ones that look smooth and shiny and not scary. And if you're my patient and you've just listened to that, sorry, I've just given away a secret. It's all psychological skills. We're looking for pictures that look nice, so that you can start building a really, really smooth image of the bladder, because kinesthetically or somatosensorially, when you ask people what their bladder feels like, they'll often say spiky, red, ragged, sore, like sandpaper. So if we can replace that with an image in their mind which is much more like looking like a nice smooth shiny organ, the better. So first they have to have a reference point, and people don't do anatomy for fun like physios, so you need to give them that reference point. So they're doing their mindfulness continuously. They do their first presentation, which is external proprioception and awareness. Then they move on to internal proprioception and awareness, so that they've got a reference for me to then talk about. Once they've done that, then I start plugging in and I work with them to find the individual language and specifically the way to approach it for that patient. So I've got one girl who we took out her bladder and her in her mind, so into a parasympathetic state. So I let her did some acupuncture, just because I know it brings on parasympathetic state. A bit more rest and repose, relaxing for 10 minutes while you're having it done is definitely going to help. Listening to Headspace, the app, or Calm, or whatever else. 10 minutes of that, and then when she was nicely in a better state, having practiced it lots, we then took out her pelvis, thought about the organs, thought about the colour, the size, the shape, how smooth, how they would feel if they were perfect, and put them back in. But with her we made it out Kevlar, so she's strong, because she really wanted to feel strong, and that gave her a good image. With someone else we put menthol flavoured organs back in, so they're smooth, they're shiny, and they've got that mentholy feeling, so it's almost like cooling. I've got someone else who she wanted watery, because watery felt smooth. Others that have had silk. You can have different colours, different textures, different whatever means something to the patient. So we spend some time putting those organs inside, and then meditating really on what that would feel like to begin with. So what would it feel like if I had this menthol bladder in me? And just imagining that feeling. And we will spend 10 minutes, 15 minutes doing that together, and then I'll send them away again to do that for a couple of weeks, meditating on the feeling of a menthol bladder. And sometimes you need to throw other things in, so there's lots of people with psychological processes going on that, I'm saying bears, that are triggering their threats, that it means that's difficult, so you've got to look at ways of doing this with a patient. Once we've got a menthol bladder in place, or whatever feels a bit more structurally sound, or whatever that patient's feeling, if they've got a weak bladder, do we need to give them a strong one, whatever we need to do. Then we start with graded motor imagery. I try to start with stuff that's easy, so not going for the stuff that's difficult for them to do initially. So the patient I'm going to tell you about had really, really, really bad pain on the release and the void and then the stop, and then it would feel better for 20 minutes, half an hour, and then it would start to hurt again. It would be achy, but then the bad pain would come back. So we did not start with, let's start imagining going to the toilet. We started with imagining going for her run, imagining going for a walk, because of course all my patients are doing interval training at whatever stage they can do, because we need to get them exercising, helps with the brain and the pain. And worked up to it, so it might be sitting in the car with a menthol pelvis or menthol bladder, or what would your bladder feel like if you then got out of the car and stood up and didn't have that immediate that weighty feeling that a lot of people will then say that's the point at which they have their sudden feeling of urgency upon standing, sit to stand, getting out of the car, that kind of stuff. Imagining those transitions is a good one to start with. But coming back to this one patient, we did all of that, and she was getting good at imagining it and doing well, and it wasn't really changing things, but she was feeling more in control anyway day to day, and a lot of her symptoms, because we're still doing alongside all this, we're still doing myofascial release for the pelvic floor, not to treat the trigger points, but to work with the muscle. And if you haven't listened to that, go and watch, what did I call it? It's not about the wand. watch that one. It's all about the other magical things that you do and how wonderful you are when you work with your pelvic floor. So we're doing myofascial release, they're doing self-release, they're doing exercise, they're doing lots of other stuff. But with her, we finally got to the point where actually we just need to look at this toileting. So we started trying to break it down, because the first few weeks where thinking and visualising going to the toilet, looking at a card, looking at someone else going to the toilet, we don't have good, what they call FODA, so the cards that are there to show an image of someone doing something, because, you know, if you start Googling it, you just end up with looking at porn, which is not what we want. We want honed images. And I know that Katie Fertel, Katie Kelly up in Canada, wherever you are, is working on it. I know Sandy Hilton's working on it. I know that there's lots of people doing it. So come on, guys, we need those images. So we started with visualization, and then we started going into the toilet when she didn't need a wee and imagining sitting on it and having a wee. So we actually went and sat on the toilet and imagined having a wee and it not hurting. And we just weren't getting carryover of any change until I added one of these. So these are two different types of toilet spray. One is Poo-Pourri and one is VI Poo. Both have lovely, lovely scents. And it just came out of the blue because one of the patients my patient had been given one by a friend who very sweetly said, maybe your issue is because you're a bit shy and you don't want to go around other people, and she hadn't really fully explained what the issue was, so she kind of said, thank you very much, but you know, Poo-Pourri's not going to help me feel better in my bladder. But I said, well, why don't we use that, and let's use it as a trigger to bridge psychologically the gap. And my thought process in that is, if we create a new language, a new story to be stored in the basal ganglia, which is our library of all different movements we've ever done and all potential actions and, you know, basically neurotags. Have we done this before? What happened? And we store it with a scent which she found pleasant. Could we then recreate it in real life using that scent? So what happened was she went to the toilet. Before she went to the toilet, she would do her relaxing meditating in, I think, like a loft room or something, and she sprayed VI Poo or Poo-Pourri, can't remember which one, but a nice spray in the air, and lay down, did all the meditation, and imagined going to the toilet and smelling this smell, because she could smell it when she was doing it. Imagine going to the toilet, it not hurting, with this menthol bladder. And absolute caveat, she was feeling better by this point anyway, so things were starting to improve. Pain had come down from kind of 9, 11 ceiling type crawling pain down to about a 6 and a 5 generally. It wasn't constant. She was having periods during the day where we were starting to get, I wasn't aware of it, I didn't think about it, it was just a bit of a nagging, it wasn't there. But then we did the spray, and over a period of time, and again, you can see this is going to take a year. This is a lot of treatment. She would spray the spray in the toilet and then have a wee and imagine it feeling good as she was having a wee. And we found the carryover was amazing. And the way that I'm rationalising it in my mind is that it's a new scent. It's almost like creating a new neurotag, new mechanism, which is associated with relief and joy and happiness and painlessness in this bladder, a new expectation. So we had changed her environment, and remember, environment can be a massive neurotag trigger. So by changing her environment, I couldn't build her a new house or a new toilet or anything like that, but what we could do is use a different scent, so smell. And smell can be amazing, because then, especially from a VIP point of view, she can then carry that with her everywhere she goes. Take it away on holiday with her and that kind of stuff. And that's what we've been using. And now she's voiding with much less pain, which is amazing and is a psychological process. So that's what I wanted to share with you, that I have been using little sneaky things to try and use different senses to build new neurotags that don't always lead to my bladder feels like it's on fire. Build new senses, build new organisations, which hopefully is going to now, it's taken a year, but break those bonds limbically, break those, not physically, but alter and change the neurotags within the brain that are always developing the same pattern, and give cognitive flexibility, which is what we're after really at the end of the day. So if you got this far, thank you for listening. It is an emerging area that we're beginning to get some research in, and I'm really excited. I'm like a big fangirl watching all of you guys that are researching it. I'm really looking forward to stuff that I've heard that might be coming out soon. And if you've got any ideas on what I'm doing, if you've got any other suggestions, please get in touch on Facebook or on Twitter, Gilly Bond Physiotherapy, or at Gilly_Bond. I'd love to hear from you so we can talk some more about how we move these patients forward with chronic pain syndromes. So thank you for listening.